And yeah, so go ahead, Rebecca. Thank you again for doing this parent coach webinar for us. And I'll let you go ahead.
Thank you. My pleasure. So good morning, everyone. I'm assuming for my friends who've been making this all work this morning, I hope you had a lot of caffeine on board to help you get through all the things that needed to happen to make this work. I love home visitors and I love home visitation. So what you're looking at here is a national curricula that was developed in 2010 that's gone through many, many, many changes over the years. And I've had the pleasure of working in every single state in this whole country, with the exception of Delaware, bringing this curricula to those states and working with folks. So it's really my heart and soul passion. What you are getting this morning is just a snippet. So if I were to come to LA and do a training with folks, it would be a full day. It'd be 7 hours of training. So what I did was I pulled together different slides from different parts of the curricula to make sure that you had a sense of what would be covered, and hopefully it can help your practice, but just know there's a lot more where this came from. So if you're interested in more, you can access the whole curricula. We can send it out. The tools that I referenced, we can send to you as well. So just know that there's more where this came from. Okay. And now I'm trying to figure out how to, okay, great. So just quickly, Futures Without Violence is the U.S. Department of Health and Human Services National Resource Center on health and domestic violence for the whole country, which means we create tools and model policies and programs and things that really help the folks on the ground. I will tell you, I have worked, as I said, in so many states with so many home visitors, and it's their voices, your voices, that have really shaped all the changes that have happened. Because we know for this to work for you, it has to feel relevant, it has to feel real, for the doors you knock on every day when you go on those home visits, for the situations you sit down with moms and kids. We know it has to work for you. So it's been a pleasure sort of working with a lot of wise folks along the way. One of the folks that really influenced me was a woman in Jacksonville, Florida. Her name is Lo Berry. And in 2001, I think I was doing a project where I did 32 site visits at different home visitation programs across the country. And I was trying to understand what made talking about violence so hard for home visitors. And Ms. Berry, who is just, I think, a saint among saints, was wise enough to walk up to me at the break and said, Rebecca, if you want my staff to really tell you their stories, you need to separate the supervisors from the frontline staff. So that, because the supervisors were frontline staff, and if they're feeling uncomfortable about how to support their staff because maybe they didn't get enough support or education when they were a frontline person, they can't say that in front of the people they're supervising. And if your supervisor's sitting in the room, sometimes it's hard to say, wow, well, this is kind of how I do this shortcut or whatever, and you don't want to say that in front of your supervisor. So you should really separate them and hear their stories and understand, so that you can create something that really works in both directions. So I want to credit Lo Berry and her wisdom for what you're getting to hear today. We're going to talk a little bit about the prevalence of domestic violence and its impact. One of the things, though, I always do, the first half of the training, if I were to come and see you in person, would really be about how to take care of yourselves. And I have this slide up here because sometimes I think if we are wanting systems to make change, if you want your leadership to make change, it's helpful to say, well, the federal government says we should do it this way. And that's actually what this slide is saying. So the Substance Abuse and Mental Health Services Administration really thinks for systems to be trauma-informed to help clients, it really has to pay attention to its own workforce. What makes this work hard? And one of the things that I can say can make this work hard is if we aren't taking care of our staff as a first step. So one of the questions I always ask systems when I go into a training is, do you have a policy for your own staff if they were experiencing domestic violence? Do you know where to go, how to get help? Is there a policy in place? And a lot of times folks say there isn't. And I guess I'm showing this for my supervisor friends in the room to say that Futures has really developed a very simple model policy that you could click on this link after the webinar and have all kinds of tools to help you as a supervisor, but also to help your staff who might be survivors and also integrate a model policy. You just type in the name of your program and it populates the policy. It tells you the places you should go to create partnerships and all those kinds of things. So I just really wanted to say, your employee assistance program, I always hope, has some specialized training on domestic violence, because we know that it happens not just to our clients, but it happens to our friends and family members and our colleagues as well. So vicarious trauma is one of the things that can happen to you all when you're doing this work. And I think the best way to describe it, and this is Dave Verselli wrote about this in 2007, but I like his description of how it changes things. And when you hear a story or when you see something that's really upsetting, what we talk about when we talk about vicarious trauma is that the way you see the world changes a little bit, right? And so my best example of this, and I was asking folks about, can you think of an example of a situation that really changed something for you? And I was in Michigan working with home visitors there, and there was a visitor who was only working with teen moms, and she had a 14-year-old who was impregnated by someone in her own family who was then incarcerated. And as she's telling us this story, her voice kind of breaks a little bit, and she says, and I have a 14-year-old niece. And she says, I can't turn it off, right? I'm always looking to see if she's okay. I'm always wondering if someone's going to hurt her. And so she said, this is how that working with this 14-year-old, how it changed me in a specific way. And so I'm saying this because I don't know that you get to hear enough about how much this work can affect you, and also what are the things you can do to help when you are affected. So one of the things that I think a lot about is, so what are some other ways caring for survivors of trauma can show up for you or your colleagues? And I think the answer is wide, right? So it's everything from I can't sleep, right? I'm worried, I'm rethinking. I often say this is when I feel like in the middle of the night is when I want to make t-shirts that say woulda, coulda, shoulda, could I have done that better? Should I have said something different? All of those kinds of things. And so we know that that's part of the worry. We also know that sometimes as people are listening to the stories of other people's pain and suffering, it can affect their personal lives, it can affect their relationships with their families, it can make them depressed or anxious, it can make them less able to be present in the work that they're doing. So we know that it also can make you feel like you don't want to go back to work, right? I don't want to listen to any more stories. It's too hard. So this whole idea, if you look at the last bullet point on this slide, you can see thinking of quitting, negative reactions to clients are some of the things that we see. And we want to help reduce the likelihood of you being burnt out and not wanting to go back to work, because each one of you on this phone, your collective wisdom, what you've learned from your families and how you can use that to help other families, is the most valuable asset we have in California when it comes to home visitation. So we want to figure out how to hold on to all of your wisdom and your heart and the way that you do your work, and support you in doing this work around violence and things that are hard in a radically different way. One of the things that I think can really help when we're talking about vicarious trauma is laughing. And I love this book. It's called Trauma Stewardship. This woman, Laura Vandernoot-Lipsky, wrote it. And this book is really about her own awareness that she was feeling really burnt out. She's kind of on this hike. She's standing at the edge of a cliff, and she realizes that it kind of looks attractive to maybe think about jumping off that cliff, because the weight that she was carrying from the work she was doing was so heavy for her. And she has lots of funny anecdotes in this book about, when you're feeling stressed out at work, does it change the way you drive? Do you get more aggressive? Do you use your horn more? What are the things that happen? She also has a 19-minute TED Talk. And so one thing to think about doing as a staff after my conversation with you today is really taking a minute, doing that 19-minute TED Talk, watching it together and talking about it, because I think it'll make you feel good. I think it'll make you laugh. I think you'll see yourselves. She's got strategies there on how to cope. I think will really help you. For my supervisor friends in the room, I will tell you I've had sort of 2 jobs in my career. One is working for Futures Without Violence, and the other was working at running public health clinics in California. So I ran a primary care site in Vacaville, Vallejo, and Fairfield, California. And I'll tell you, I went from being a frontline staff person, kind of working my way up all the ranks, to kind of being the director of these sites. And for my supervisor friends on the phone, it's not like I went to supervisor school or manager school. I was just trying to, do my best. And all I knew was what I knew from being a frontline person. And there's no shame in knowing that. So what I want you all to feel empowered to do is know that you're not alone, because that's a lot of how our systems are set up. You kind of run the ranks and then you find yourself in a supervisor position. But if you're trying to figure out how to create an environment that really supports your staff and helps you support them around vicarious trauma and what builds resiliency, what helps people, this is a toolkit for you. So it was developed at the federal level at the Centers for Homelessness, because the burnout rate is very high there. But the reason I think it translates to home visitation or any kind of healthcare setting is that it's a series of tools that really help you analyze everything from what's your lighting like in your environment, to what does your break room look like if there's such a thing, to how are you allowing staff to let their voices be heard and shared. What kinds of things are you doing to counter all the hard things? And so you don't have to reinvent the wheel. It all exists right here. And it's just a great tool for my supervisor friends on the phone. So why is it important for folks to know about domestic violence? Why? And I'm going to ask folks to use their chat box now, and hopefully that'll work for me. But why do you think it's important for you to know about domestic violence? What kinds of things come to your mind? Safety. Nice. Thank you, Sonia. Others? Anybody else? Why is it important to know? I think safety certainly is a part of it, and we're going to talk about that. But I think the other thing that I think is super important here is that if you think about any of the goals that you have as home visitors, good maternal health outcomes, good pregnancy outcomes, children's mental health and emotional health, and their physical development all being supported, parenting skills, family safety, all the goals that you're trying to achieve, if we don't look at the issue of intimate partner violence, those wonderful things you're working toward can diminish or even disappear. And this is some data from Nurse Family Partnership that really looked at the impact of intimate partner violence on overall outcomes for home visiting programs. And you can see here it says the effectiveness of home visitation services in preventing child abuse, which is actually why these programs were created in many, many cases, is diminished and may even disappear when a mom is being victimized by her partner. Now, a number of you said you thought about the word safety. That what about your own safety? And I think that's a really important thing to think about. I don't know if all of your programs have a really robust, a really good policy to promote your safety, but we do at Futures, and this is again something you can download or have access to after this webinar. We had worked with Vermont Home Visitation, had done a lot of work on developing a really comprehensive safety program policy for staff, and it was one of the best we had seen. So we got permission to take their tool and use it. So I want you all to know that we've been thinking about you, and there may be ideas there that you hadn't thought of before. So what is intimate partner violence? I think the best way to describe it is it's not a one-off, right? So it's not a one-time thing. It's not like somebody slapped you across the face and that sort of is intimate partner violence in the way that we're thinking about it. We're really thinking about it as a pattern of power and control in a relationship, and that can show up in a lot of different ways. It can be physical, it can be emotional, It often gets worse over time. And power and control can show up in ways that, you don't get in trouble for. So, Futures really thinks about intimate partner violence as a public health issue rather than as a criminal justice issue. So if you have a client of yours who has a partner who won't give her money to get to where she needs to go for her prenatal care, or to be able to come in for a visit, or, takes her cell phone so she can't call her family or make, emotional connections, that kind of isolation has huge health impact, affects her pregnancy, her stress level, all of those kinds of things. But they're not things that he could be arrested for, So what we're looking at is how this power and control can show up in these ways that people don't necessarily always think about, including money, right? So who controls the money? Who controls access to food? If she goes to WIC and gets her food from WIC for herself and her kids, is the partner eating all of that food? Is he giving her access to that food? So these are the kinds of things we want to think about. In terms of prevalence, we have some nice data resources available to us to look at it. So we know that 17% of home visited moms reported either physical or psychological abuse within the past year. And then we know that depending upon what your story is as a mom, your risk of IPV goes up. So we know that when we look at moms who are poor, who aren't married, that the rates of intimate partner violence can be as much as 30%. And we know in rural settings, which I think some of you may be working in some rural settings, and maybe in agricultural, situations, or with migrant farm workers. In rural settings, the incidence of intimate partner violence may be as high as 50% during the perinatal period. And one of the things that we often do is we take a state, or we take a data set from a state, and we say, okay, well, how does that help us think about intimate partner violence in home visitation? What lessons can we learn from this? So this is data that came out of Illinois. So we're looking at data that they pulled from 2017 and 2018. And if you look at that first box, it says percentage of participants screened for intimate partner violence within 6 months of enrolling. So that was their goal. And you can see in 2017, almost 80% of the moms were screened within the first 6 months. And in 2018, 93% of moms were screened within the first 6 months. Great, good job. And then what the next column is looking at is, of the moms who said, yes, I'm being hurt, what percentage of them were referred to a domestic violence agency or given some kind of resource and support around that? In 2017, 40% were given a referral to a domestic violence agency. And in 2018, 75% were given a referral. So we see that goes up. That's good. But the thing that you really want to pay attention to is this last box, right? So if you look under disclosures, in 2017, only 2% of moms who were asked about violence said, yes, that's happening to me. And in 2018, only 4% said, yes, that's happening to me. Now that's important to look at, because remember, the rates are much, much higher than that. So what we know from looking at Illinois, and I think this is very similar across, I think it was a great example, and it kind of cuts across our experience with multiple states, that the disclosure rates are very low relative to what we know is really happening in people's lives. So what today's webinar is really trying to do is help us think about, well, why is that? And what should we be doing differently to make sure that we could connect with all those moms who are experiencing intimate partner violence? I also think it's really important to acknowledge that it's a health disparities issue. So we know women of color experience more violence than white women. But I have this up here because I want you to put a pin in that. I want you to think about that for a second, because this next piece of data is really important for all of us to understand. Because this says when differences in income, education, and employment are considered, the differences around race diminish or disappear. Meaning, if we could deal with poverty, if that was a way for us to think about how do we help end domestic violence or reduce domestic violence, intimate partner violence, the answer is we make sure that folks have meaningful jobs where they can make enough money to support their families, that they have access to education, and that they have enough money to feed their families. And I think that's really important, because if we were to think about intimate partner violence as a bigger story around health equity and what we need to do to make the world right, we have opportunities to sort of change what we're doing in our systems. So I know a lot of you have heard stories about people who are being hurt in their relationships. And I'm just wondering again if you could type in the chat box, why might a person stay in a relationship when intimate partner violence has happened? Why do people stay? Why do people stay? Why do people stay? Fear, no other support, financial security for the kids, shame. Nice list, people. That's great. And you've got a lot of them. They don't have their own income. Maybe there's religious reasons, right? Maybe it's a sin to get divorced. Feeling hopeless, fear of getting deported. Thank you for saying that. Absolutely. So love, right? I didn't have a father, so I want my kids to have a father in their lives. There's so many complicated reasons about why people stay. But of all the things I'm going to say to you on this webinar, this little stop sign hand is the one I want you to remember. So if 77 of you are on this call, I hope if I were to do a little exit interview with all of you, you would be able to say this back to me, which is, if you only take one thing away from this, leaving a relationship can never, ever, ever be the goal. So I know as home visitors, we want to make it better. We want to fix things. We want to help. That's why you come to this work. And I think sometimes people think, oh, well, if we get her to leave a relationship, that's a good outcome. But if you look after the yellow writing, it says leaving comes with the highest likelihood for homicide or being killed by her partner or acute victimization. So staying might be your safest choice. And I really liked these last two lines in red. And this comes from my domestic violence advocacy friends. You know, we really need to change our thinking away from why hasn't the survivor left to asking, what can I do to support this mom with what she needs? And that's what moms need from you, is how can you best help her? And in some cases, the best way to help her is to help her get out into a safe house, right? So that might be the best outcome for her. But we really need to let her drive what's happening because of the danger associated with leaving. So we know that violence really impacts your health. We know that 43% of pregnancy-associated homicides were IPV-associated, meaning a whole lot of folks are vulnerable, and they're vulnerable in ways that we don't necessarily always think about. We also learned that 54% of pregnancy-associated suicides involved intimate partner conflict attributable to the suicide. So I think it's really important for us to be thinking about how violence shows up, because I think a lot of times we think about sort of the more common reasons that there might be a death of a mom, right? So pregnancy-associated homicide and suicide each account for more deaths than other obstetric complications like hemorrhage, embolism, preeclampsia, the traditional causes of maternal mortality. And I don't think most folks realize that or know that. We know it makes sense, right? So moms who are being hurt, it's harder for them to stop smoking, drinking, or using drugs. And they're using those things as a way to cope in a situation that is incredibly hard. We also know that during pregnancy, low birth weights and preterm births happen, and that moms may, who are in violent relationships, this sort of makes sense too. If you think about who owns the breasts, right? An abusive partner might be the one that thinks that they're the owners of those breasts. And so we see a decrease in breastfeeding among women who are in a violent relationship. And if you've got moms who are experiencing persistent postpartum maternal depression, That's another big piece that we see as well. So I've talked about a lot of things, right, that are connected to the health outcomes, connected to your experience as home visitors and how it can affect you, and how important it is for us to do this in a way that's meaningful. So cues, and I love this little picture, so I hope you can see that there's this little girl who's whispering into the ear of another little girl. And I love this picture so much because it looks like she's hearing the best secret ever. And that's really how we feel about our evidence-based intervention cues, because it's really, again, through the lens and the eyes and the hearts of home visitors, clients, of survivors, and of providers that has really kind of led to this. So healthcare providers, we know, make a difference. When you, and I think of all of home visitors as healthcare providers, that's what you're doing. You're helping support the care and well-being of pregnant and parenting moms. We know that when you talk to them about healthy and unhealthy relationships and situations where they might be experiencing violence or power and control, that folks are more likely to get some help, whether it's calling a hotline, getting advocacy, getting some counseling, getting an order of protection, or anything like that. We're more likely to access those things. I also think it's really important that we acknowledge that we're not all in the same place around intimate partner violence right now. So while I can't separate my frontline staff from my supervisor staff, this is a moment for each of you to kind of look at this scale. And I want you to don't type in the chat box. This is a personal exercise for you. But I want you to think about, if someone were to say to you, yes, that's happening to me, how comfortable would you personally be with disclosure? Would you be in the blue? So if I said to you, oh my gosh, this is happening and I need your help, would you feel like, okay, I know what to do and say, Rebecca. I know how to support you. I know where to refer you to. I know how to do a little safety plan with you. I know how to do all these things. I've got this, right? How many of you are in the blue? How many of you are in kind of this green area? You kind of know what's going on, but you're not quite sure. You're not quite sure if you feel totally comfortable. And then, I'm going to have some friends that are in the yellow and red, and I don't want you to feel a darn bit of shame around that, because that's what this webinar is about, right? This is about helping you have more tools to deal with this. And some of the reason why we spend so much of our day in the beginning talking about vicarious trauma and personal trauma is because for some of you, you're survivors yourselves, or you witnessed violence in your home. And so when you're talking to clients about intimate partner violence, stuff gets stirred up inside of you and it feels overwhelming. And again, nothing to feel ashamed about, but we got to talk about that and really think about, how do we support you in doing this work differently? So where are you? Are you in the blue? Are you in the sort of medium blue, the green, the yellow, or the red? In the, please don't say anything to me. Please don't tell me your story because I can't handle it. I don't know what to do. So think about where you are, because I'm going to ask you at the end of this if anything changed for you. So this is a moment where I'd like you to type in the chat box again. How many of you have or know someone who has left something out of a medical history on purpose or misreported information to a healthcare provider? How many of you have done it, or you know someone who's done it? And everybody's very quiet. So I feel like maybe we need more coffee. Well, when I do this live, if I were in a room with you, a lot of you would raise your hands, but some of you wouldn't. And then I'd tease the people who didn't raise their hands, because I think there's a lot of good reasons for us not to share information. So why do you think people don't share information with their healthcare provider? Shame or guilt, good. Why else? Fear. Yep, who's going to learn about this? What's going to happen? What else? Not ready to hear the answer. Nice. Taking the kids away, absolutely. So consequences. So let's think about this in the context of intimate partner violence. So fear of deportation, you mentioned. There's so many good reasons why moms remember back to that Illinois data I showed you. So only 2% in 2017 were saying, yes, this is happening to me, and only 4% in 2018. But we know the number is much greater. Well, these are some of the barriers, right? So part of what Futures is doing is really pushing systems, home visitation, other systems, to think outside of their traditional model about screen and refer, screen and refer. I'm going to ask you a question like, have you ever been hit, kicked, slapped, or choked by a current or former partner? And I just want you to think about that for a second. If I'm afraid of deportation, I'm not going to say yes to that question, even if it's true. If I'm afraid you're going to remove my kids, I'm not going to say yes to that question, even if I need help. And I would love to get some help from you. I can't trust the system enough to get the support and help I need, which is the opposite of what we're trying to do in home visitation. So this is huge, right? This is a really important part of what we want to change. You know, you all knew automatically that one of the biggest reasons people don't say their truths is because they're afraid of child welfare services. And that's actually what the research has borne out too. It's what when we interview women in home visiting programs, they say things like this. If mandatory reporting was not an issue, she'd tell the nurse everything about the abuse. I say no when my home visitor asks me about abuse because that's how you play the game. People are afraid of social services. That's my biggest fear. Like I was saying about my friend, the reason she don't disclose is because she thinks the nurse is going to call children's services. So she avoids the nurse a lot. So let's think about this for a minute. Everything we're trying to do to help people, we've created the system where they can't. So what are we going to do to make it right? I think the other thing we've really been learning about is what this slide is talking about. And again, this is from Nurse Family Partnership. But the use of a structured screening tool, so the kind of tools that you might use. And by the way, please keep using all of the tools you're supposed to use so that you don't lose any funding. Please, please, please don't stop doing what you're supposed to do. But what we're working on at the federal level is really taking this data and saying, hey, are we doing it the best way possible given what we know is true? So this is me kind of making that case for California or for LA in the same way that we're also making it at the federal level. So here you can see the use of structured screening tools like that question I gave you earlier. Have you ever been hit, kicked, slapped, or choked? Does not promote disclosure of women's experiences of abuse. So I think that that's really important to think about here, because if I were to walk into your kitchen and you sat me down and you said, hey, Rebecca, come have lunch with me. I don't know what you make me. Maybe you make me tacos, maybe you make me a sandwich, whatever you'd make me, which, by the way, I would love. And I'd say, oh, I love your kitchen. The tacos are delicious. The sandwich is delicious. The lemonade is great. And then I would turn to you and say, okay, Olivia, so I'm wondering if your partner has ever hit, kicked, slapped, or choked you. In the same way, I would never ask a friend that, or a sister that, or a mom that. Neither does it make sense to keep going down this road with clients, because they're humans too. They're people, right? So home visitation is all about this relationship, and I know you know that. But I actually think the way some of these tools have been created kind of get in the way of relationships sometimes. And so what we're wanting to do is don't keep doing your paperwork, please, please, please. I don't want you to lose funding. But this is a way, I think, to make up for the fact that these questions that with good intent systems have come up with because they're worried about people's safety, we're trying to figure out how to do an end run or do a little work around those particular tools. And if you look at the second bullet point on this slide, right, women are more likely to talk about violence when you talk to them about their lives. Are you how's it going in your relationship? When they talk about safety, when they talk about healthy relationships, people are more open to talking because you're really talking to them and not asking them questions like you do with a screening tool. So one of the things that we think a lot about is this idea of a brave space. And the funny thing about checklists is some people love them and some people hate them. And I think sometimes the people that really like checklist is it's a way to feel sort of a little bit more in control of what's happening in an interview. But if you think about it, the way this is set up, and Illinois is my great example, right? They screened all of their moms for violence, and the only way you got help or resources is if you said yes. But that means that we leave, the other 15% or the other 28% or the other 48% of the women who need help completely without resources, because we're not looking at the fact that their lives are so complicated, or they're afraid, or they're worried about stigma and shame, or they're worried about deportation, or whatever the things are that they're worried about. They're so afraid of those things that they can't tell us what's going on. So what we've been thinking a lot about is this idea of health equity and social justice in health. How do we make sure that the world is more equal? Because some people, if their lives are especially hard and marginalized, or if they've come from a situation where they've already been in the system, maybe they were in foster care, maybe they had a parent that was incarcerated, maybe they had all kinds of complicated things happen, or they witnessed happening in their own families, or that they themselves have experienced. How do we make the world a little more right? And especially when we're talking about intimate partner violence, given we all just talked about why it's so hard to tell people our stories, we have to do something different. And I think especially this is true around the issue of thinking about equity and in particular mommies of color. And I don't know if any of you had a chance to read this New York Times article in 2018, but the title of it was why America's Black mothers and babies are in a life or death crisis. And it has everything to do with racism. And what this article was really powerful in showing was that we often think about, well, the reason women of color have worse maternal outcomes, or low birth weight babies, or higher maternal death or infancy death is because they're poor, they don't have access to health care. But in fact, this article was looking at middle class Black women as compared to white women. And they found that they also had much higher rates, like 4 times the rate of maternal mortality as compared to their white counterparts. So, and they had access to insurance, and they had access to care. So what you then understand is that this is about racism, and this is about huge disparities in our system. And how do we as home visitors, how do we as folks who care so much about the people that we go into their homes and become part of their families, how can we do things differently? So racism, the risk factor for maternal health, racism is, and in here again, just using Illinois as a case study, we know that non-Hispanic Black women are 6 times more likely to die of pregnancy-related conditions as non-Hispanic white women. Black women are about 3 times as likely to die within a year of pregnancy as compared to women of any other race or ethnicity. And homicides accounted for 15% of all pregnancy-associated deaths for Black women. And in contrast, homicide is a very rare cause of pregnancy-associated death for white women. So we can't watch this together, and if we were live, we would. But I love, love, love this woman so much. If you haven't heard of her, I think this is a TED Talk worth watching. It's only about 15 minutes long, and this woman's name is Miriam Zoila Perez, and she calls herself a radical doula. I love a radical doula, who really weaves together this understanding of how racism, inequity, and our healthcare system has really is something that we have to take on if we want to really make a dent in these big issues, and ideas about what can help. And in this particular TED Talk, she's talking about the JJ Way, which is a midwife in Orlando, Florida. Her name is Ginny Joseph. And she has changed the way that she's decided to do maternal care. And what she's done is she's managed to, through doing it in this very different way, which is, mom-centered, She creates a cozy environment for folks to come in for their care. You're never in trouble if you're late. Everyone's thrilled to see you. You get to do your own urine tests. You get to do your own weight rather than having someone else do it for you. That you're part, as the mom, you're part of this team, and you feel like it's supporting you. And the outcomes are tremendous. So we know that in the same hospital Jenny Joseph's babies are born, babies who are born to folks who've gone to other OBGYN providers, their rates, the maternal mortality rate, look the same. It's at least 4 times greater versus the Jenny Jones clients, which are Jenny Joseph clients who carry these full-term babies to term, have healthy outcomes, and it's all about changing the way that you do the system. So this is our opportunity around intimate partner violence to be thinking about, well, how can we change the way we do what we do? And what I get excited about is really thinking about how this health equity lens can save lives, because what our radical notion is today on the phone together is, what if we challenge the limits of disclosure-driven practice? Which means if I ask you that question, have you ever been hit, kicked, slapped, or choked, and you say no, that's it, right? I go on to the next thing. I say, great. So tell me about what you ate yesterday, or whatever your other next question would be. If we've set up a system where if I don't say yes to you, you can't help me. And that's what we want to change. So we want to have all of you be doing universal education with clients about intimate partner violence. And the way that we are training folks to do this is through using these little cards. The cards are the size of a business card, and they have multiple panels. I'll just show you. Here's an example of one of the panels of the card. So how's it going? All moms deserve healthy relationships. Ask yourself, do I feel treated with respect and kindness? Do I feel safe and supported? Does my partner support my decisions about when or if I want to have more children? So these little cards are set up to support you as home visitors in being able to have conversations about healthy relationships and ones that aren't healthy, and where people can go to get support and help. The magic sauce, the way that we are training folks to do this in a way that allows for everyone to feel safe and really recognizes that, especially for the folks who are most marginalized or have been most hurt by systems, they need the most support. And so here's how our research has taught us that this is a really important strategy for these moms. So I've started giving 2 of these cards to all of my moms. So you'd hand 2 of those cards. It talks about healthy relationships and what to do for ones that aren't safe. I always give you 2, so you have the info on how to help a friend or a family member, because we all know someone who has or will need help. So think about that. Now, I want to hear in my little chat box, as you're reading this, tell me about what comes up for you. What do you think that would mean to one of your clients if you offered this to her in this kind of way? What do you think would happen if you did the script, you handed 2 of these cards to your clients? What do you think it would mean to them? More open communication? What else do you think it would mean? I started giving 2 of these cards to all of my moms. Talks about healthy and safe relationships and ones that aren't. Why is that important? I always give you 2 so you have info on how to help a friend or a family member. Why is that so important? It might plant a seed for a later talk, interaction. Nice. It also does this crazy other thing, right? So I just transferred some of my power to the person in front of me because I said, you're someone who can make the difference in the life of someone else. So I want you to think about one of your moms who's been told she's worthless, nobody would ever want her, she's a bad mother, she's a bad person, she's in this controlling, ugly relationship. and the power of saying you're someone who can make a difference. And I think part of the magic sauce here is that sometimes we are willing to help other people when we aren't even willing to help our own selves in that same way. I also think the reason this is so important is because it allows everyone to take the information, because everybody wants to help other people, right? And so then I don't know if you're taking the information for yourself or someone else, and it doesn't matter. And that's the key. That's what makes this big difference, is that everybody is leaving with really important information, and it creates a deeper relationship between you and the person that you're working with, right? And altruism is what this is called, right? And I think there's some nice data about this. I love this, and in our experience, folks have really loved this approach. So the power of social support is more about mutuality than about getting for self. I think that's true for you as home visitors, but I also think it's true for the moms that you serve. That is, there's a need to give, to matter, to make a difference. We find meaning in contributing to the well-being of others. And your moms do too. So that there's a piece of this that's about healing. There's a piece of this that's about making the community healthier. There's a piece of this that's about helping your mom or your sister when you didn't know how to, right? So we all do know someone who's needed help, and we haven't known how to help them. So the ways that this all works together is pretty incredible. One of the panels of the card that is most the favorite of a lot of the moms is this one. It says helping another mom. So everyone feels helpless at times, like nothing they do is right. This might be true for you or someone you know. Connecting with other moms about what's hard and where you find your strength might help you feel less alone. So there's all these little pieces of wisdom. And one of the things that always comes up when I'm doing this talk is like, what if I have a mom that doesn't read? Or what if I have a mom that has low literacy level? This was really developed for you as home visitors so that you knew how to sort of start these conversations and help a mom understand how this Hughes intervention can make a difference for others. And so you can read out this card or sections of the card or use it as a place to say, what do you think about this, right? And kind of read it aloud if you know that reading is an issue for them. And it gives you a way to have a conversation about something that can feel a little awkward bringing up, but I think this really helps you as a home visitor to be a guide. So cues, when do we do it and how often do we do it? So the first thing is safety first, right? We never want to do universal education in front of other people, not partners, not mother-in-laws, older children. We never want to leave the cards without the client making it's clear it's safe to do so. Who gets it? All female clients. And when would I give it? On the first visit, because we know sometimes that may be the only visit your mom ever has with you. It may be that she needed to move or something else changed in her life. So I think this universal education approach about, we're doing this with all the moms in our program because we really care about our community and we really want everyone to be part of making it better. However your script would work, I think that's just a super important thing to do. And then obviously anytime there's a disclosure, we'd want to be using this as a way to follow up and support. So cues, the C stands for confidentiality. We see the client alone. We talk about the limits of confidentiality, and I'll talk more about that in a minute. We're going to normalize the activity, right? So the UE stands for universal education and empowerment, because how you frame it really matters. I've started giving 2 of these cards to all my moms because relationships can change. I give you 2 so you have the info on how to help a friend or a family member. And then you want to open up this card because it's multiple panels, and you just kind of want to use that as a way for yourself to remember to touch on all the highlighted points here. It talks about healthy and safe relationships, ones that aren't, how they can affect your health and pregnancy. It connects things that you might not otherwise see, like how substance use or depression can be connected to hard relationships. You might want to change that. You might want to focus on the panel of the card that's about, it talks about how to help other moms, because we know that being pregnant, especially if it's a first-time pregnancy, can really be a really hard and isolating thing, especially if you're away from friends and family. And you can tweak it, but we really want to always give 2 cards every time, explain it's for the client if they were to need it, or someone else, so that they know how to help. And then S and Q stands for support. On the back of the card, there's a plan and 24/7 text and hotlines that have folks who really understand complicated relationships. And you can also talk to me about any health issues you have. So what do we know about our interventions? We've done a lot of research on this, and I loved doing the research on this project. I had the opportunity to interview both providers and survivors, and here's what one of the providers said about the cards. The card made me feel empowered because you can really help somebody that might have been afraid to say anything or didn't know how to approach the topic. This is a door for them to open so they can feel more relaxed about talking about it, and I think that's really true. Here's what a client said. They would bring out the card and basically walk in with it, and she'd open it and ask me if I'd ever seen it before. It was awesome. She would touch on no matter what situation you're in, there's someone or someplace that can help you. I don't have to be alone in it. That was really huge for me because I was alone most of the time for the worst part. So one of the other things that we see is that this little card becomes a talisman, I don't know if anybody's ever given you a special rock or a worry stone or something to hold on to kind of keep you going through a hard time. And I've had any number of conversations with clients who said, I had that in my wallet for a year. In fact, this is a home visitation story from Iowa. So PJ West is the woman who runs the home visitation programs for the state of Iowa, and Iowa was one of the first states to bring Healthy Moms, Happy Babies statewide. And she says, I had a client who pulled out her card a year after it was given to her and said, I want you to know I held on to this, I looked at this, and, I was finally able to make a change in my relationship. I moved back in with my mom, and I held on to this all that time. And I didn't feel ready to talk to you about it till now, but I wanted you to know how important it was to me. And here's what another client said. Getting the card makes me actually feel like I have a lot of power to help somebody. So I want to say this too. So universal education can also be used as a stepping stone to then have more direct questions with a client. So sometimes when I hear about anxiety, it makes me think about relationships and stress. How's your relationship going? Are you guys having are you having a hard time right now? That kind of thing. So you can ask direct questions after you do the universal education as a follow-up. But I think the reason the universal education is so important is for those clients who would not have ever had any other information about where to go to get help, that they weren't alone, to normalize it. All of those things are so important to the universal education process. And these, asking more direct questions can be a follow-up to that. So I know one of the things that folks are doing are looking at substance use and abuse. And I think that there are ways in which this card can be used with other kinds of tools that you're using with your mom. So if you're doing the Edinburgh, I'm going to say that wrong. If you were in the room with me, you'd help me. But I have a little bit of, I can't say the word brewery, and I can't say the Edinburgh depression scale. I never can get that one right, so forgive me. But you can see how you might use this with that tool. So how's your health? How are you coping? Do you ever feel so sad you can't get out of bed or take care of the kids? All those kinds of things. You might use this as a universal education about, hey, so we're going to do this screening tool on depression, but one of the things that I always like to do is kind of talk a little bit about what this card is looking at, because I just don't think people kind of hold it in that way necessarily. And so I just want to make sure, you have a chance to think with me about what we've learned about why it can be hard to quit smoking, or why it can be hard to get out of bed, or how relationships can really affect your mental health and your ability to get help for substance use. So S is that safety and support. The disclosure isn't the goal, but it's going to happen. So people are going to tell you their stories sometimes, and I want you to be prepared for what to do and say then. And again, it always breaks my heart because this is, I'm doing this so quickly, and know that there's more information for you, because this is in no way comprehensive. But I want you to have a little sense of what the literature says about what do women want. And, I think it's intuitive, right? They want to be listened to, and they don't want you to be judgmental. They don't want you to push for more disclosure. They want you to offer information and support, which is really what universal education is doing. So our friends, Lee Kimberg and her colleagues at San Francisco General Hospital have been doing amazing work. There's a website called LEAP, L-E-A-P, all caps. You can get this sample safety plan off of Future's website, but I want to acknowledge that that's where it came from. And the beautiful thing that Lee did was this was done in multiple languages. So you're seeing, this is a bifold, this is an 8 by 11 piece of paper, and you're seeing one side of it. So there's more safety planning on the inside of this. And they have it in Spanish and Tagalog and Farsi, and the list goes on. So it's many, many languages. So I thought that would be especially helpful for you all in LA. You don't have to reinvent that wheel. I will say that sometimes the only person your client is going to talk to is you. And I really would encourage you as home visitors to ask your supervisors, and my supervisor friends, bring in your local domestic violence advocates so that they can talk to your staff and your staff can understand how they can help them, because that's their job. I also think for my domestic violence advocate folks, they have 50% of the folks who are in shelter are children, and most of those are 5 and under. So you've got folks that you could be working with, pregnant and parenting moms in those programs, and we know that your services can bridge much longer than domestic violence advocacy services can. I was just doing work in Oregon, and I don't know how each of your programs are structured, but one of the things that came out of that is that advocates are now accompanying home visitors when they get permission from moms to come on visits with them, to support them in having these bigger conversations or providing deeper safety planning. Ideally, you'd want an advocate to do this with a mom. The domestic violence hotline number can do that with you. You can be on the phone with the mom while they do that and help them think through this. But if that mom is only willing to talk to you, then I would say that this tool is a very helpful one for you to help a mom have strategies about how to be safer and how to have a plan for it. Because we all know when we're really upset in the moment, it's very hard to think on your feet when you're panicked. And so the beauty of the safety plan is it allows you to plan in advance, think about what you'd want to pack in a bag, what key information, green card, whatever the pieces are that you'd want to, your child's inhaler, the things that you'd want to have if you needed to rush out the door. I like this idea of an active referral to a DV agency. Sometimes making that first step can be the hardest when you're wanting to get help, even if it's just to talk to someone. So I like this quote in yellow. If you like, I can put you on the phone right now. Ideally, it's great if you know the name of, your local advocate, with Sheila, with Maria, and they can come up with a plan for you to be safer. And really offering to dial that phone number and be on speaker with them is really helpful. Also, to use your phone and not theirs, because if you've got an abusive partner, they're really looking at their call logs. So you using your phone might help increase her safety in ways that you wouldn't have guessed. But please always think about the importance of using your own phone in those circumstances. On the back of the card, it has 2 hotline numbers. The hotline is the domestic violence hotline number. There are always English and Spanish speakers on that line. They're 24/7. They're out of Austin, Texas. And they also have a language line where I think 178 languages are spoken. And if you're in a situation where maybe you speak a little of the language, but not a lot, the language line can help with talking about domestic violence or translating questions or even education that you're wanting to do with your client. So don't underestimate the power of that resource for yourself. The second one for treatment referral is that SAMHSA hotline for substance abuse and mental health. So they can help connect you based on zip code to folks who could maybe help in those circumstances. If you've got a mom who's struggling with a heroin addiction, for example, and you're wanting to figure out, well, where could she get treatment, or where can moms get treatment? They would have lists of those kinds of resources for you. Same thing with the domestic violence hotline number. If you haven't had a chance to meet your local DV agency, don't worry, because the hotline is connected to every domestic violence program in the whole country. So if I say I'm in 94703, they're going to know that there are 4 shelters, one in Alameda, one in Oakland, one in Berkeley. I'm using my own zip code. You know, they're gonna know all of the local resources for you, so you don't have to worry about figuring that out. I really do want you to meet with your advocates because different programs have different kinds of services. So some even have programs for kids healing from domestic violence. Some have help with legal advocacy, so they can help with a restraining order. The advocate can go with the mom to court. They can help sometimes with divorce papers if that's what's wanted. They can help with transitional housing. So the more you partner as home visitors, the more I think we really help the community, because you've got 2 different funding streams coming together around this family, around this mom. And that can really be a way to leverage expertise and also leverage resources. The fastest way to get to our materials on our Futures website for health is this website. So ipvhealthpartners.org is where you can get these tools, and we can get you the safety cards and the safety planning tools and the Healthy Moms, Happy Babies card, and the whole curriculum lives there. So I asked you all to really think deeply about where you were on your needle. So were you really comfortable with the disclosure of domestic violence? Kind of comfortable, really uncomfortable, like really in the red, it's so painful for me. I hope your needle moved a little bit as a result of listening to the webinar today. And I just want to kind of do just a recap of what we covered, right? So basically the cues approach is really important to think about versus screening alone. And I hope I've said this enough times for every supervisor or director to know that I don't want you to do anything other than continue with your important paperwork, because while we're trying to make changes at the federal level, it's really important that you follow the guidelines that are there, but nothing prevents you from doing cues in addition to everything else you're doing in your program. And in fact, what we see is that when people use cues before they do the screening tool, it softens that transition, and it allows for you to have conversation before you've asked a question that gets a yes or no answer, which really shuts down the conversation. There's no conversation after, have you been hit, kicked, slapped, or choked, and you say no. In fact, and that question doesn't even begin to look at all the ways power and control are showing up and affecting pregnancy and parenting, right? It doesn't look at emotional abuse. We're trying to prevent physical abuse. It doesn't look at social isolation. It doesn't look at all the other ways power and control shows up around economics, access to food, access to transportation. So I think it's just really important that we're holding this cues intervention as a way to augment or supplement the things that we are required to do for our programs. We talked about a confidential environment, never do universal education in front of other people, don't leave safety cards around without checking it's okay. You've got to explain what's inside of them. We talked about harm reduction strategies. We talked about warm supported referrals to DV agencies and growing partners with DV agencies, which is so crucial to this work. So quickly in your chat box, I want to hear a little bit about your thinking. What stands out for you? What do you need more of? And what's changed in your thinking? Oh, can I repeat the website, please? So it's ipvhealthpartners.org. And always you can just go to Futures Without Violence, and there's a tab that says Health. So that makes it easy. So what stood out for you in today's training? What do you need more of? What changed in your thinking? What changed in your thinking? Anything? Goal is to help clients in their situations, not help them get out. Yay, Joanna, thank you. Other things that stood out for you? Providing info. Cards will be very useful to provide to our clients. Cards, great idea. We'd love to access. We have them in Spanish. I really like the card. Card will be really useful. Great. Wonderful. The goal isn't to help clients leave. Thank you. The goal is to help clients with what they need help with. And just you acknowledging some of the things that you learned today, I think can be so powerful for the people that you're serving. So we're just going to do a little mindful movement. I know I can't see you, but look at my very cute toddler. Wrap your arms around yourself. Left hand over your right arm and rub your arm and give yourself a squeeze. And then switch arms and rub your left hand over your right arm. I think that's right. And give yourself a squeeze, because I want you to all to feel a little grounded. We covered a lot in a very short period of time. So you want to stretch your arms in the air, wiggle your fingers and shake your hand, roll your shoulders a little bit, come back to center. And I'm going to leave you with this thought, and then we'll go to questions. But this is a story that's written in my skin. It's a story I will never forget. And this is what a young woman who received the card shared with me. So there'll be times where I just read the card and remind myself not to go back. I'll use it so I don't step back. I'll pick up on the subtle stuff because it'll trigger me. I'll remember what it was like. I remember feeling like this. I remember going through this, and I'm not going to do it again. For me, it just helped me stay away from what I got out of. I carry it with me, actually. I carry it in my wallet. It's with me every day. So I'm going to ask my friends on the webinar who have been coordinating today's efforts, if there were questions that came in through the chat, or if people have questions now, maybe you could help just, excuse me, pull those up so I can answer them.
Thank you, Rebecca. I think there were two questions that you've already addressed, which was, what was the website, and are the cards available in Spanish? And I think those were both addressed. The answer is yes, and ipvhealthpartners.org.
So other questions now. We have about 15 minutes left. So if folks have other specific questions or other ways I could be of help, please use this time and let me know.
We'll give you all a minute to collect your thoughts and type it into the chat box. Any questions? So I'm going through, I went to the ipvhealthpartners.org, and to get the card, do we just download the PDF toolkit? How do we get that?
That's a great question. So we send the cards to you. Futures is a national nonprofit, so we don't charge you for the printing of the cards. We charge you a small shipping fee, so maybe $5, $10 or something like that, and we can send you, 200 cards or 500 cards, and you can tell us if you want them in English or in Spanish, and certainly you can download, if you want to look at the whole cards. The PDFs are on the website, so you can look at them, and there are lots of other tools for pregnant and parenting moms. There's another tool that you really might like called Connected Parents, Connected Kids, that's looking at adverse childhood experiences in parents and how that can affect their parenting and what can help with complicated issues. So, so I think, yes, you can get the PDF, but you just, there's a button on our website where you can order them.
Okay. So I can send that information out with the notes so that everyone can know properly where there's how to do that, because I think there'll be a lot of interest in people getting that. So it doesn't look like there are any other questions, but it sounds like your presentation has been well received. And I see a question from Rosalie about getting a copy of this PowerPoint, and I will send that out along with the notes. And as we are recording this presentation, we'll be posting it on the Stronger Families blog, and we can put all of these resources up along with the video. And I'll send that link out as well.
Great. Okay. Do you have any other questions for me?
I do not.
Okay.
Does not seem. I don't see any other new questions in the chat box, so I think we can let you guys know if you have any questions. How do we connect with an advocate? Pilar is asking a question.
Oh, great question. So remember how I mentioned that the National Domestic Violence Hotline can connect you to the advocacy resources that are closest to you? So you can call the hotline and say, hi, my zip code is blah, blah, blah. Which are the 3 closest domestic violence agencies? Or, again, you may have a Spanish-speaking only population you're working with. So you'd maybe want to say, which are the shelters that have, you know, full-time Spanish-speaking folks? And that there'd be others, you know, that folks really feel like there's more of a connection, because there's culturally specific places. You can also look in your phone book or whatever, but certainly the hotline would be a helpful place for you to know what's available. Sometimes if somebody does want to leave a relationship, it may be more helpful for them to actually be out far away from their own zip code, you know, going to Modesto, for example, or coming up here to, you know, Northern California, to Oakland or to Berkeley or whatever. So just know that. And I can pull up a list of LA specific, I'm sure I can, LA specific programs, so let me know that too. And I can send that out to you as part of the packet that gets sent to folks. Okay?
That would be great.
Okay.
And if anyone has any other further questions, feel free to direct them to me, or Rebecca has her email address right there, if that's okay with you, Rebecca.
Of course. Okay. Well,
so we can end there. Yeah, thank you. So like I said, we'll follow up with all the materials as soon as we can, and I hope you all have a wonderful rest of your week, and thank you for your attention and your questions, and we'll talk to you soon. Thanks again.